Hello, this is a talk on dizziness aimed at ED. So the big problem with dizziness is, sorry, I'm trying to read this, the first time I've done a recording things. Key thing with dizziness is it continuous or episodic? So people will come in and they'll say, I'm dizzy. Step one, do you mean you're fainting and you're lightheaded and you're going down a cardiac route, a neurological route, or bleeding to death route, a T-lock syncope route, or do they mean the world is spinning round and I am feeling sick? So if it is proper vertiginous, vertigo, spinny dizziness or unsteadiness, and it's continuous, then you're worried about, is it a stroke, if there's associated neurology, or is it a labyrinthitis, which actually isn't a labyrinthitis, it's a vestibular neuronitis. That's a big thing. Or are they getting dizzy, but they're not dizzy all the time, they're normally fine, but they get attacks of dizziness that are really debilitating and they're horrible and they've come to hospital. Amongst all those things, there are all sorts of other things that are around dizziness. Drug causes, brain tumours, otitis media making you feel dizzy, and a lot of that will come out in the context. So if someone's got obvious signs of sepsis or at least infection and they're dizzy, that's taking a whole different route. These are people who are otherwise well, it's pretty unexciting, but they are dizzy. The first one to look for is BPPV. So BPPV is very, very common, particularly in older people. So BPPV is people they're fine, but doing certain things will make them dizzy, and your job is to tease out what those are. Classic one is rolling over in bed to look at the alarm clock. They go dizzy. And if you've got that history, then that's done. That's BPPV, and you can go on and treat it. Sometimes it's just moving their head across the road. Sometimes it is just getting out of bed or getting out from a chair. But often you will get the history of BPPV. You can test for BPPV by doing the Hall-Pike. Doing the Hall-Pike is really, really easy. You can do it in the frailest people imaginable. In ED, where you've got a trolley where you can get the head of the bed down, it is a lot easier. What I often do is just sit somebody up, put the head of the bed down, and then just gently lower them backwards. As long as you get the head over to one side and the ear is sort of below the heart, in other words, you've properly got the what you're looking for is a semicircular canal, but as long as you've got the ear down into the side, you will provoke BPPV. And it's very, very obvious when you see it. You get someone just to look straight ahead, and if they get I'll come into the camera, if they get a rotatory nystagmus, often it's just a little sort of flickering movement. It can be subtle, but mainly if it provokes their symptoms and you get it one side, sometimes you get it both, but that pretty much takes them to what they've come in with. Well done, got a diagnosis. If you're really bothered about bringing someone, if you're throwing someone around a bed, you can do a Semont manoeuvre, and Semont manoeuvre is you ask them just to put their hands over their chest and they look away from the direction of travel, and you just lower them to the side. And the nice thing about the Semont is that if you're dizzy that way, you can treat it just by bringing them the other way. You just need to do that a few times, and that's diagnostic and it treats. And that's often really easy to do, and actually you can often do that with people who are feeling a bit fragile more than you can the Hall-Pike. That's BPPV. It's really easy. Wrong key. The software doesn't work if I use slideshow, that's why I'm doing it this way. Otherwise you can treat with the Epley. The thing about the Epley is Google Epley manoeuvre and print it out. Don't try and look clever by remembering how to do it yourself, you'll just get it wrong. Print out a sheet with the Epley manoeuvre on, do it there in ED if you've got 2 minutes spare, and then hand the patient the sheet. Marvellous. Ugh. So the other version of dizziness, which is quite common, is what is usually referred to as labyrinthitis, but it's not labyrinthitis. It's vestibular neuronitis or vestibular neuritis. It is paralysed eighth nerve. So the eighth nerve isn't working on one side. The brain's getting unbalanced signals from the ears. You feel really nauseous and really, really dizzy and really vertiginous. So this is a continuous dizziness. So if someone's saying, oh, I'm just feeling awful all the time, this is what you're looking for. And this is essentially what the HINTS examination is designed to pick up, if you've heard of HINTS. So HINTS is head impulse, nystagmus, and torsional skew test, which is rubbish. But the head impulse and nystagmus is very useful. So often you want to start off with the nystagmus. So someone's really dizzy and you say, okay, fine, sit there, face me, now look all the way to the left. They look that way. And then look all the way to the right. And they look that way. And that is often enough to bring out the nystagmus and the symptoms. So that's a great place to start. And if they've got that and you carry on looking at them and you can't really find anything else wrong, bingo, they've got vestibular neuritis. If you're not getting it with that, then you can go head thrust. So head thrust is ask them to look at your nose. I'll take my glasses off. Ask them to look at your nose, slightly lower the head, and you only need to make small movements with the head. So they're doing that. And actually the optokinetic reflex is incredibly exact. So my eyeballs should have been following the camera exactly with that. If there was a lag, so if I've done this, that's a positive test. So something's gone wrong there. Or if doing that had provoked nystagmus, that's a positive head thrust. And it's pretty obvious when you get one. So you can get a sort of subtle lag, or you can get full-on provoked nystagmus and provoke symptoms. And again, that pretty much means that you have got vestibular neuronitis, unless there's some obvious other neuroscience. It's a really useful test. It only has to be small movements, so you don't have to worry about bad neck. And then the last thing you're meant to do is the skew test. Have I got a slide on the skew test? Oh yeah, I've got a skew test. The books say to do a skew test. The skew test is doing this, and as you uncover the eye, it's meant to go up. And if you've got that, that's meant to be a sign of stroke. I don't know. I've seen a lot of strokes. I don't think I've ever seen a positive skew test. Anyway, the Americans rave about it. So if you do all those things, you have got you can often make a pretty sound diagnosis of vestibular neuronitis. Depending on where your level is, you might want to phone a friend and ask a senior just to confirm that, because you don't want to miss a stroke. The other common form of ENT dizziness, or neurological dizziness, is vestibular migraine. And vestibular migraine is people who have had an attack of really bad dizziness and they also get migraines. They don't necessarily have to have a headache with the dizziness, but you can just get a migraine attack that just localises itself in your ears, and that is a vestibular. So vestibular migraine is essentially somebody who's dizzy. They're known to have migraines, and the rest of the examination isn't desperately conclusive. So you can go down that route, and it's meant to be quite common. You treat it as you would any other migraine. So those are your classic ENT causes. Other causes are going to be someone who started a new drug. There's quite a lot of drugs that will make you feel just a bit nauseous. And then any other cause of nausea. So often they're talking about dizziness, actually what they mean, they just feel a bit sicky, and they could simply be constipated or have cholangitis or diverticulitis, or it's just early signs of infection. Obviously UTI in the elderly often presents with appalling nausea, so you've got to be sort of careful on seeing what people actually mean by their symptoms. When it comes to stroke causes of dizziness, because really you're looking at posterior circulation strokes, there's a lot of clot work in the posterior circulation, and if you've got an area of brain affected there, you should get more than just isolated dizziness. Sometimes you get caught out, and that's why there's things like the skew test is there. If someone's gait is particularly badly affected, out of proportion to how dizzy they are, that is a bit of a red flag, and that would indicate stroke. Otherwise, what you're looking for is hard neurology, so slurred speech, proper good-going diplopia, out of context, of not diplopia whilst they're getting the provoked nystagmus, but ongoing diplopia, facial weakness, facial numbness, look in their mouth, is their palate asymmetric? It's usually, it's nice picking up a brainstem stroke because they've often got quite nice hard neurology. Otherwise, for cerebellar strokes, you would expect to be getting a lateralizing incoordination or a really, really bad gait all the time. And the thing about stroke dizziness is that it can't really be overcome by keeping your eyes open, so you don't get a lot of difference between eyes open or shut. I am going to pause there.